Okay, so today I'm going to talk about implant technique. Who and where. First, pacemakers were originally implanted by surgeons in the operating room, but today pacemakers are implanted by cardiologists or electrophysiologists in the cath lab or EP lab. They can also be done in the OR, but more commonly in the EP lab. Today, during a pacemaker implant, you have local anesthesia. It's an outpatient procedure. Sometimes they stay overnight just so they can check the leads the next day, and it's routine. So for equipment, you'll need standard surgical equipment, same instruments. You'll need the pacing equipment, so we have introducers. On the case yesterday, we used 8 French introducers, and then guide wires. You use fluoroscopy, you use X-ray. You use an EKG. And then the patient system analyzer and programmer is all in the equipment that we bring. So to place the leads, like I said, local anesthesia, doctor makes an incision in the subpectoral space. He makes a pocket similar to a pocket in a shirt, just right under the skin and under the fat layer. They get venous access, so Dr. Ben-Zur did the cephalic cut down, you saw that yesterday. But you access the subclavian vein, cephalic vein, or internal jugular veins. But most commonly, you aim for the subclavian. And then the pocket's formed. So in dual chamber systems, the ventricular lead is placed first because this is the pacing lead, the most important lead. It's introduced into the vein and guided by X-ray to the RV apex or the RV outflow tract, and then you could just pull back. The position is verified by fluoro, and then we put the testing cables on, and the rep tests it to make sure it's a good placement. We test sensing and threshold. And a threshold is minimum amount of energy required to make the heart pump. So we just lower the voltage until we lose capture. You can tell by morphology of the QRS, and the threshold is the lowest voltage that made it capture. So ideal RV lead position is the RV apex. The leads are either active fixation where you screw in a helix or passive fixation with the tines. I showed both of you those. So you check sensing and pacing. And then right atrial lead positioning, that's typically done after the RV. And they use a J curve stylet to get it to go into the right atrial appendage. And it's a good position if you have a good windshield wiping type motion. It's touching the tissue there. Back and forth rocking of the J shape can be seen on X-ray. That's what you're looking for. And then for the RV lead, you're looking for a good heel, so you have enough slack. So when the patient takes a deep breath or stands up, there's enough slack, there's enough extra lead there, because they're laying down versus sitting up. So then we use a PSA to test. We also test 10 volts to make sure that the pacing stimulus does not capture the phrenic nerve, which runs on either side of the heart. So the doctor will either just look on fluoro or feel. So in textbook, you want thresholds under 1.0 volts, and you want greater than 2 millivolts sensing P waves, greater than 5 millivolts sensing R waves, and then less than 1 volt. So less than 1 volt at 0.5 milliseconds capture threshold. If it's a difficult case, or say the patient has a lot of scar, I have accepted higher, but ideally under 1 is better. And typically the next day it's either the same or even goes down, because the pacing leads have steroids at the tip. So when you first screw in the lead, or even a passive lead, you kind of bite into the tissue and it causes an acute inflammation, and that can elevate the threshold temporarily 1 to 2 days there. So to combat that, they started adding steroids 10 years ago to the leads, and it helps a lot. But even with the steroids, the next day the threshold can come down.
Is the steroid it's temporary, right? Because it'll just be in there for the implantation and then reduce the
threshold.
Inflammation.
Yep, you're right. Just it's released, I think, like 2 days maximum, and then that's it. There's only a little bit in there.
That's really cool.
It's cool. Yeah, it's dexamethasone.
Okay.
is the steroid that we use. I think we all use that actually. So once everything is acceptable, the leads are in a good position, the pacemaker, we open up the pacemaker and it's inserted into the pocket. Well, before that, you plug in the right atrial and right ventricular leads, and use the hex wrench, and you screw it in. And then the pacemaker is put in the pocket. And then with St. Jude, we have Bluetooth in our pacemaker, so we can check everything right away, that everything's in the right position, the thresholds still look good. And that's it. So then we speak to the doctor and we talk about programming. What's the base rate do you want? What AV delays do you want? And then we program accordingly. Do you want rate response on, rate response for chronotropic incompetence, that type of thing. So in conclusion, pacemaker implant is typically done in a cath lab or EP lab, but may also be done in the OR. It's often done on an outpatient basis. You use transvenous leads. To get venous access, you use fluoro, x-ray. You do perioperative testing, capture thresholds and sensing, and then you put the pulse generator in the pocket, suture everything up, and talk about final programming. That's it for the pacemaker implant.